Bismillahirrahmanirrahim. We will start with quote of the day, which is indeed what is to come will be better for you than what has gone by. I am Dr. Taimia Ayub, and today I will be presenting the topic of translational, operational, and implementation research and priority setting in health research under the kind supervision of Professor Dr. Saira Afzal, Dean, Institute of Public Health, Lahore. So we will start with learning outcome of today's presentation. First, we will define and distinguish translational, operational, and implementation research, explain the continuum from basic science to real world health impact, apply frameworks for research priority setting in LMIC context, critically analyze examples from Pakistan and global health setting, identify barriers and enablers of research translation in public health practice. Session outline the research to practice gap, and then translation research and its types, and defining of operational research, implementation research, comparing all these three. What do we mean by priority setting in research, related frameworks and tools, and examples and perspective of Pakistan, low and middle income countries, and global perspective. So, what is the research to practice gap, and why this does this gap exist? 17 years is the average time for research findings to reach practice. Knowledge generated does not mean that knowledge is being applied. Most research conducted in high income countries implemented in lower middle income countries without adaptation. Weak linkage between researchers, policymakers, and program managers. In Pakistan, about 3% of health budget allocated to research. Implementation gap is even wider. So, what do we mean by translational research? According to the definition, translation research is that transforms scientific discoveries into practical interventions that improve human health. So, for that, we have four levels: T1, T2, T3, and T4. So, T1 is from basic to applied level. For example, lab or bench discoveries into candidate interventions. Then we have T2 from applied to clinical level, in which clinical trials are done. Does it work under controlled condition? Then we have T3 from clinical to practice, guidelines, protocols, dissemination into health system. And then we have T4 from practice to population level, real world effectiveness, equity, and scaling up. For example, for translational research, we have the global example of oral rehydration therapy, in which T1 fluid absorption physiology was discovered. In T2, RCTs confirmed efficacy. In T3, WHO guidelines were issued. And at T4 level, 50 years later, it is still underused in diarrheal disease globally. mRNA COVID vaccines, which is the fastest T1 to T2 in the history, only duration was about 11 months. Then we have Pakistan specific example of zinc supplementation for child diarrhea. Efficacy proven in RCTs at T2 level globally. T3 gap is that national guidelines were updated in 2010. And then we have T4 gap, less than 30% of diarrhea episodes treated with zinc or ORS in Pakistan. Lessons: T2, T3 to T4 is the hardest transition in LMIC's system, not science. So the main key point is that most translational failures occur at T3 and T4 level, the stages most influenced by health system capacity, policy, and context. Then we have few other examples. For example, HPV scaling immunization globally. Lab discovery was done for HPV vaccine technology T1, which demonstrated near perfect clinical efficacy in preventive cervical neoplasia during trial phases. System transition: the translation from T2 safety guidelines to T3 rollout required substantial Gavi financing mechanism to lower cost for developing nation. Population impact evaluated globally across multiple LMICs, illustrating massive drop in vaccine type cervical HPV strains T4. Again, we have Pakistan-specific example of TCV in Sindh. An outbreak of extensively drug-resistant XER typhoid emerged in Hyderabad and Karachi. The strain was resistant to first-line drugs, fluoroquinolones, and ceftriaxone, leaving physicians with severely limited and expensive treatment options. Translating basic trial data into public health response, Pakistan became the first country globally to launch a mass campaign using WHO pre-qualified typhoid conjugate vaccine. It successfully translated clinical efficacy data directly into large scale pediatric safety and impact evaluation. So, these are few of the examples of translational research. Now, we come to the next topic, which is the operational research. Operational research, according to WHO, is the research on activities or tools that can be used to enhance the delivery and quality of health programs. What it studies, it can study program inputs and processes, coverage, uptake, and adherence, health system performance, service delivery bottlenecks, quality of care within programs. Where it is done, it can be done within existing health programs, real world routine settings, government, health systems, NGOs, not necessary in controlled trials, typically embedded in programs. Key questions: are we reaching those who need services? Why are people not using these services? What is preventing the scale up? How can we do better with the same resources? What works here and why? Again, we come to the examples of operational research. First, we will start with the Pakistan specific context example. Typical study design include cross-sectional surveys, cohort studies within programs, record reviews or audits, and exit interviews, key informant interviews, and mixed methods, program data analysis. Pakistan, we have the first of all TV program DOTS example. Operational research identified treatment default rates of 15 to 20% in Punjab. Root cause analysis via exit interviews revealed transportation cost, stigma, and DOT supervisor absenteeism. Program restructured mobile DOTS delivery accordingly. Then we have the process of EPI program modernization. A systematic analysis of low income immunization campaign showed 76% of interventions mapped to operational primary health levers. Integration of vaccine analytics network with localized stock management led to a dramatic drop in district level stockouts. Operational testing verified that automated SMS reminders directed at fathers significantly reduced second dose dropouts. So, operational research does not generate new knowledge, it generates actionable evidence within programs. Now we have global examples for operational research. For example, short TB regimens. Historically, TB treatment for multi-drug resistant tuberculosis spanned 20 to 24 months, causing high dropout rates, severe side effects, and astronomical patient incurred cost in high burden countries. Through pioneering operational research championed by the Union in Bangladesh, a 9-month regimen was tested and optimized in standard programmatic setting. Real-time programmatic feedback demonstrating an 84.4 success rate, fundamentally updating WHO guidelines. Another example is of MSF HIV program in Malawi. Operational research showed 40% 2-year ART retention when community health workers provided adherence support versus standard care. It led to a national policy change within 18 months, a rare rapid T3 level success. So, these are some of the examples of operational research from Pakistan and global context. Now we move to implementation research. It is defined as the scientific study of methods to promote the systematic uptake of research finding and other evidence based practices into routine use to improve quality of health services and outcome. So we have the concept of fidelity. Is the intervention delivered as intended? Reach, who is being reached and who is not? Adoption, are providers or organization taking it up? Sustainability. Will it continue providing the study period? Will it continue beyond the study period? Scaling up. Could it be expanded to larger population? Equity. Are benefits distributed fairly across groups? So this now we come to frameworks and Pakistan specific example of implementation research. In Pakistan, we have the example of lady health workers. Lady health worker program delivers family planning, nutrition, immunization to about 130 million, more than population. Sorry. Implementation research question. Why is contraceptive counseling coverage only 47% despite high lady health worker contact? CFIR analysis revealed inner setting, supervisor workload, individual provider bias against spacing versus limiting, and the process, poor job aids. It resulted in the redesigning training and peer supervision group, which led to 18% coverage increase in 1 year. Now we have consolidated framework for implementation research or CFIR. It has different domains. So the first one is intervention, and the level includes characteristics. Key questions are evidence strength, adaptability, and complexity. Then we have outer setting of context, patient needs, and external policies and funding. These are the key questions. Then we have domain of inner setting at the organization level, and the questions are regarding capacity, culture, leadership, and networks. Then we have domains of individual at the level of providers, and the key questions are regarding knowledge, beliefs, and self efficacy. Then we have the process domain and at the implementation level, and the key questions are planning, engaging, executing, and evaluating. So, implementation science asks not does it work, but why doesn't it work here? And how do we make it work? So, now there is a short comparison between the three types of research, which are translational, operational, and implementation. So, the primary question is in the translational research is does it work? For operational, the main question is how well are we going? And for implementation research, the primary question is how do we make it work? So, if we just look at these three questions, it gives us a fairly good idea about what we are dealing in each three types of these researches. So, the setting for translational research is from lab to clinical to population. For operational research, it is within existing program, while for implementation research, it can be any real world setting. So the design can be RCT, cohort, or trial, clinical trial for translational research. For operational research, it is usually survey or audit or mixed method. And for implementation, again, it can be mixed method or case studies. What are the outputs? So for the translational research, the output is efficacy or effectiveness data. For operational research, it is the program improvement, and for implementation research, it is the scaling up of scale up guidance. Timeline can be years to decade for translational research, months to 2 years in operational research, and for implementation, it can be anywhere between 1 to 5 years. So the key actors are academic researcher for translational research, usually program manager for operational research, and research practice team for implementation research. So, according to Pakistan relevance, translational research is an emerging um, domain under CPSP and Al Khan University and other also networks. Then operational research is strong, National Tuberculosis Program, API audits, etc. And the implementation research is also growing. For example, lady health workers, MNCH programs, etc. So this is a brief comparison between the three types of research: translational, operational, and implementation research. Now we come to research priority settings and why it matters. So, what priority settings achieve is that it aligns research with national burden of disease. includes voice of communities, not just experts, distributes scarce research funds equitably, reduces duplication and fills evidence gap, and also improves health system relevance of findings. So now we come to a few key frameworks and methods for priority setting. First of all, we have Child Health and Nutrition Research Initiative. It systematically scores research options across answerability, effectiveness, potential, deliverability, equity, impact, and burden. It is used by WHO and governments. Then we have Essential National Health Research. It is the process for countries to develop nationally owned research agendas, emphasizes stakeholder participation, poverty focus, and systems perspective. Then we have James Lind Alliance, which is partnership priority setting. It brings patients, carers, and clinicians together to identify treatment uncertainties, reduces research agenda captured by industries. And finally, we have Council on Health Research for Development. Builds LMIC capacity for priority settings, focuses on national ownership and research to policy pathways. Pakistan usually is using essential national health research, though implementation is inconsistent, unfortunately, across provinces and across different time periods. So let's explain CHNRI framework, which is a practical tool for LMICs. So the first step is to defining context, finding out burden, system capacity, and equity. Then we come to point two of collect options, systematic reviews, and expert opinions. Then at stage three, we have scoring of independently multiple stakeholder groups. At fourth step is to weighing of criteria by societal priorities. And finally, at the fifth point, it is the ranking and reporting. Final priority list with the rationale. So the five scoring criteria include answerability. Can research produce valid answers? Effectiveness. Will it reduce burden if implemented? Deliverability. Affordable, scalable in local context. Equity impact. Benefits the worst. Does it benefit the worst of? And finally, sustainability. Maintained beyond initial funding. For example, if we take the example of application in Pakistan, Al Khan University applied CHNRI framework to maternal and newborn health research priorities in Sindh in 2017. Top ranked priority was community based kangaroo mother care for low birth weight infants. It led to operational research program now embedded in maternal and neonatal health policy. So, of course, there are several barriers to research translation in Pakistan and across LMICs. Weak research system, few universities with research infrastructure, limited PhD capacity, low publication rates in peer-reviewed journal. Then we have policy research disconnect. Researchers rarely engage policymakers, evidence not backed for decision making, short political cycles versus long research timelines. Funding dependency 90% plus of Pakistan health research is donor funded. Agendas are unfortunately driven by global priorities and not local needs. Capacity gaps limited training in operational and implementation research methods in public health curricula, few embedded researchers in the program. Data systems, HMIS data quality is not up to the mark currently. No linked administrative datasets, verbal autopsies or CRVS coverage is less than 30% nationally. Research culture is academic promotion based on publication, not impact. Insufficient incentive for policy relevant research, and there are silos between disciplines still. So now we come to enablers. What makes research a translation succeed? Critical successful factors include to embed research, researchers co-located within health programs, not outside looking in. Co-production, policymakers and communities involved from question setting to dissemination. Rapid cycle learning, real-time data feedback loops rather than waiting for final reports. Knowledge brokers, dedicated personnel who translate evidence for decision makers. Policy windows, timing research output to political budgetary cycles. local ownership, national institution lead rather than international partners. And HMIS strengthening better routine data reduces for expensive one-off studies. So, health and demographic surveillance sites, HDSSS, in more than 20 LMICs provide longitudinal population data embedded in health systems. Research output routinely fed into national planning. It can also work as model for Pakistan. Again, this is a diagrammatic description of from question to policy. It is a practical research cycle starting from identifying a problem and priority, then stakeholder engagement, designing study, and then finalizing its methodology, collection and analysis of data, dissemination and engagement of policy. This is very important, which is unfortunately missed in most of the settings. And then we have implement and evaluate, and then we are back to identifying another problem or priority. So Pakistan definitely has a health research landscape with its strengths and challenges. Strengths include class institution like different doing their work, strong field epidemiology infrastructure, then large cohort and surveillance systems, active GBD collaborators and IHME partnership, growing postgraduate public health program, including FCPS, MPH, PhD, etc. Challenges include research budget is usually very less. HEC focuses on publication count and not on policy impact. Brain drain is for more than 40% of medical graduates, unfortunately, emigrates. Fragmented provincial health data, no national longitudinal cohort, limited operational and implementation research training in curricula. So these are some of the challenges. And again, this is the summary which we have discussed so far, which include translational research bridges discovery to population health impact. T1 to T4, most LMICs failure occur at T3 to T4 level, not T1 to T2 level. Operational research works within program to improve delivery. It is rapid, contextual, and directly actionable by program managers. Implementation research asks, why doesn't it work here? Studying the context, process, and actors that enable or block scale up. Then we have research priority setting, which is a systematic ethical process, not an ad hoc decision. CHNRI ENHR provides structured frameworks for LMICs. And the Pakistan research to practice gap is real and costly. Embedded, co produced, need driven research is the path forward. Now we come to multiple choice question portion. So we have the first MCQ. A provincial health department in Pakistan introducing zinc supplementation guidelines for childhood diarrhea, but uptake remains poor despite evidence of efficacy and national recommendation. Which interpretation best explains this challenge? The problem reflects a weak translation between health system adoption and population level implementation. The evidence remains inadequate because randomized control trial have not been completed. The intervention failed due to poor biological plausibility in local population. The problem indicates that translation research should stop at control statistics. And finally, E, the issue mainly reflects lack of laboratory validation. A. Yes, it is A. Now we come to second MCQ. A district tuberculosis program uses routine patient records and exit interviews to identify why treatment default rates remains high despite drug availability. Which features more strongly characterizes this as operational research? It focuses on generating universally generalizable evidence through experimental methods. It evaluates implementation fidelity across different organizational settings. It is embedded within routine program delivery to improve service performance. It aims to establish biological mechanisms underlying patient non adherence. And finally, E, it prioritizes theoretical modeling before program modification.
D.
So according to my key, it is C. It is embedded within routine program delivery to improve service performance for operational research. A researcher studying low contraceptive counseling coverage among lady health workers investigate provider beliefs, supervisory structures, and organizational barriers before redesigning training programs. Which research orientation is most applicable? A. Translational research because it assesses whether contraception works biologically. B. Operational research because it only examines program outputs. C. Clinical effectiveness research because it compares intervention efficacy. D. Implementation research because it explores contextual barriers to uptake. Or E. Basic science research because provider behavior is being observed.
D.
Yes, it is D. Which scenario most appropriately represents a T3 stage of translational research? A. Discovery of a new vaccine platform in laboratory experiments. B. Conducting a randomized trial to assess safety and efficacy of a vaccine. C. Evaluating national level reduction in disease burden after vaccine rollout. Or D. Translating clinical evidence into treatment protocols and program guidance. Or finally, E. Assessing long term population equity after intervention scale up.
C.
So it is D, translating clinical evidence into treatment protocols and program guidance. So this is according to my key. A public health researchers in Punjab wants to prioritize maternal health research using criteria such as answerability, deliverability, equity, and sustainability. Which framework would be most appropriate? Consolidated framework for implementation research, James Lind Alliance Priority Partnership Model, Child Health and Nutrition Research Initiative Framework, or WHO Expanded Program on Immunization Assessment Model, or E Essential National Health Research Process alone.
C.
So, yes, the answer is C. Sorry. Which statement best distinguishing implementation research from operational research? Implementation research focuses primarily on laboratory testing before program delivery. Operational research evaluates how program functions, whereas implementation research investigates how evidence based interventions can work in context. C. Operational research seeks global generalizability, while implementation research avoids program settings. D. Implementation research only uses randomized trial, while operational research avoids mixed methods. Or E. Operational research is limited to policy evaluation rather than service delivery.
B.
Yes, it is B. In Pakistan, many research findings fail to influence practice despite publication. Which barrier most directly explains this disconnect? Excessive integration of policymakers into research design, strong HMIS systems limiting opportunities for innovation, C. A mismatch between research evidence and program financing alone, D. High levels of local ownership reducing external influence, or E. Weak engagement between researchers and decision makers with limited translation into policy.
E.
Yes, it is E. Now we come to MCQ number 9. A research team evaluating HPV vaccine introducing examines intervention, vaccine introduction examines intervention adaptability, organizational culture, provider beliefs, and implementation processes. Which frameworks are they most likely applying? Consolidated framework for implementation research, ENHR National Agenda Setting Framework, CHNRI Prioritization Framework, Demographic Surveillance Modeling Framework, or E. James Lind Alliance Uncertainty Framework.
C.
So it is consolidated framework for implementation research, as they are dealing mostly with those that part. MCQ number 10. Which statement most accurately reflects the rationale for research priority settings in LMICs such as Pakistan? It primarily reduces publication times for academic institutions. It ensures that all research focuses only on infectious disease. C. It enables equitable use of scarce resources while aligning research with disease burden and stakeholder needs. D. It replaces program evaluation with donor directed agenda settings. Or E. It eliminates uncertainty regarding intervention effectiveness. So
E.
it is C. It enables equitable use of scarce resources while aligning research with disease burden and stakeholder needs. This is the MCQ of these MCQs. This is the YouTube link where this video will be uploaded. And thank you very much for listening.